assistant, a full-time PA in Hawaii. Um, let's see, I'm currently practicing in urgent care. I've been a PA for almost 3 years. I think my 3-year graduation anniversary is coming up, I think in a couple of days, which is crazy to think. But I've been practicing for about 2.5 years, from like the first time that the first job that I got when I started. So, yeah, excited to be here today. Thank you guys for having me. As always, you're welcome to ask questions at any time. I'll go through the chat maybe after I'm done with my presentation and answer any questions that you guys have. So let's get started. Okay, go to my screen. All right. So a little bit about me. I grew up in Georgia. I am multilingual. I speak my native language and then English and Spanish. I took a lot of Spanish from third grade onwards. And then my minor in undergrad was in Spanish as well. I got a bachelor's in biology from Armstrong Atlantic State University. It's a school in Savannah. My pre-PA patient care experience, I was a certified pharmacy technician at CVS. And I did this throughout undergrad and a little bit after undergrad. My master's in biology is from Purdue University. I worked as a research assistant at the Indiana University School of Medicine the year that I was applying to PA school. And I studied wound healing on diabetic mice who with MRSA infection. So basically to determine how diabetes plays a role in wound healing, because it's a well-known fact that diabetes slows down wound healing. So we were testing it further on diabetic mice. I got my master's in physician assistant studies from South University in Tampa as president of my class. So graduated in 2018. I tell all of the pre-PA students that I work with that I highly recommend getting involved with your executive board or some organization within your PA school class. Just gives you a good outlet outside of the rigorous and stressful um, course of PA school. So as president, I got to organize events with the help of many others in my class. And then I also got to sit in on the interviews. So I got to see, kind of everything kind of comes full circle when you're on that side of it, because you kind of see the CASPA, you see the personal statements, you see everything that kind of makes an application whole, and you get to meet all these students and talk to them. And so that was probably one of the most rewarding parts about being president of the class. I am a practicing physician assistant, like I said, practicing for about 2.5 years. My first job was a locum tenens, which is like a temporary position on a military base. Since then, I've practiced in pediatrics and sleep medicine, and currently I'm working full-time in urgent care. AP the PAC, as many of you guys may know on Instagram, it's a pre-PA mentoring service, and I host try to host, like I used to do it every week and it's kind of slowed down because of work, but I try to host virtual shadowing sessions as much as I can, free webinars. I had one yesterday on writing the personal statement for PA school. And so I try to do a lot to help you guys out as far as PA school is concerned. I do have one coming up. I haven't posted it yet, but it will be like a pre-PA question and answer. I'm doing it like 2 or 3 weeks before CASPA opens. So any questions that you guys have, feel free to attend and ask all of your questions. I will be doing it most likely in conjunction with another PA. She and I will be kind of tag teaming questions together, and it'll just be a very informal presentation. For the mentoring part of it, if you're one of those students that needs guidance, this kind of package is for you, and we can talk about that more later if you guys have any questions about it. Let's see. So pharmacy technician, I get asked this a lot as a pre-PA, what does a pharmacy tech do? So pharmacy technicians, they fill the patient prescriptions as ordered by the medical provider. Of course, you're working with the pharmacist at all times. We educate patients on programs available for medication maintenance. We all know about, like Walmart has like a $4 generic prescription drug program, that kind of thing. So I was doing it for CVS, of course. Communicate with insurance companies for drug coverage. So when you have patient that comes in and their medication is not covered by insurance, we try to call insurance companies, figure out what exactly isn't covered, and what maybe what an good alternative is that the insurance company will cover, that kind of thing. Educate patients on the uses and indications of medications within my scope of practice. And of course, you learn medication indications, brands, generics, and then dosages that you commonly encounter. You also gain exposure to part of the patient care experience, right? So I get to see patients after they've already been diagnosed. But I don't get to see the beginning half. So I don't know what symptoms brought them into the clinic, what kind of, what testing was run, what was done to have them diagnosed with X, Y, and Z condition that would then need this medication that they're in the pharmacy for. So why did I go into medicine? Why did I choose a PA path, and why did I create the platform? So for why did I go into medicine? I had a family member that was very sick with a brain tumor. And when he was really sick, I didn't really understand why he was sick. I didn't understand why he was getting so sick so quickly. So many questions. And so I realized I was interested in medicine through his health journey. And as a result of that, I decided to go into medicine. And then I shadowed a PA. My pharmacist's daughter happened to be a PA in cardiothoracic surgery, so I shadowed her. And then I also had appendicitis, and I was treated by a PA. So I had a dual exposure to a PA. I knew what a doctor was, I knew what a nurse was, I knew what a nurse practitioner was. I had never heard of PA before. My first encounter was as a patient, and then I went on to shadow. And so um, I really like the lateral mobility of the PA profession. I like being able to just pick up tomorrow and decide that I don't want to do urgent care anymore and I want to go into, I don't know, psychiatry. And just my biggest struggle then is finding a job in psychiatry, and not worrying about having to go back and go through residency or go through any additional like formal training to be eligible to become a psych PA. I also like the fact that there's this balance of autonomy and collaboration. I practice on my own. I've never worked with any physician like physically in the clinic with me since graduating from PA school, but I do have a slew of physicians that I can call anytime I want. I do have a supervising physician that I have on my license and all of that, but essentially I can call any physician within my company. I've called my medical director so many times for complex patients as I continue to learn and transition into urgent care. And so I really like that because it definitely enhances the patient care. Can make a big difference in patient care too, because maybe what I was initially thinking isn't the best treatment, or maybe what I was thinking is, and I have somebody else confirming it with me, which is also nice. So I do like that part of it. And why did I create the platform? I myself was a second time applicant to PA school. I didn't get in my first time. And so, one, it's helping pre PAs hopefully avoid having to apply more than once. That's my biggest thing. And the second is this virtual shadowing. That's actually how I started AP to PAC, was offering virtual shadowing. And through that, I kind of wanted to kind of raise awareness for how valuable virtual shadowing can be. I don't think that it certainly doesn't replace in-person shadowing, but I also think that virtual shadowing has, you gain exposure to specialties that maybe in person are very hard to reach, like gaining exposure to I had a friend, a colleague in our classmate in PA school who practices in Southeast Asia, and she did a virtual shadowing session with me. And I think that was really cool because I mean, nobody's going to be able to go to Southeast Asia and shadow her, but she was able to do a virtual shadowing. So students were able to learn from her as far as what her day to day entails and what she does as an international PA. So I do think that there's some validity in virtual shadowing for examples like that. It's just a platform to help you guys in general as much as I can, help you gain more exposure to the PA profession, help you kind of gain shadowing, especially during this pandemic. And then if you need further guidance, then of course work one-on-one with students for their application and prepare them to become the strongest applicant they can be. So here we go. Okay. So lessons learned as a second time applicant. So if this is anyone in this group, this is a good slide for you. So of course it's a maritime marathon, not a sprint. The biggest thing we do as pre-PA students is checking those forums and comparing our statistics to other students. But we don't know what goes behind those statistics. We don't know if they're only counting classes that they've retaken, or if they're only counting their, their prereq courses that they took way after undergrad, but maybe they didn't do as well in undergrad. I mean, you just never know. But as students and as humans, it's common to just anchor on, oh my gosh, this person has a 4.0 and they've already heard and gotten an interview and an acceptance, and I still haven't gotten anything. It's human nature. But my biggest recommendation is, once you submit your application, just get off the forums, because they're not doing you any good, right? They're not changing your statistics. They're not changing you as an applicant. But what they are doing is adding stress to an already stressful time as you wait to hear back. Failures and setbacks, of course, are motivation. Very, very hard to believe that. It's easier said than done for me now. When I was going through it, it was difficult to remain motivated, because you just keep thinking like, I'm doing everything I can do. I don't know how much more I can do to get in, but you just keep going. Super important to prepare ahead of time. I cannot stress to you enough how important it is to prepare ahead of time. Every year that I work with students, I do get students that start preparing around this time. And, it's not impossible. You still have a month at this point, but it has to be, there's a lot more shifting in your priorities if you start preparing right now for an application that opens in 4 weeks, because we don't realize how much goes into having to take your GRE, or something as simple as your personal statement. It takes a lot of time to write. Everything is about how you word it, your CASPA experiences. If you were a medical assistant and your CASPA experiences is talking about how you were an MA, but it's not really effectively describing that what you've learned and how many skills, or what skills you've gained. How great is that experience if you can't convey that to an admissions committee? That's the kind of stuff that I'm here to help you with. But it takes time. So ideally, if you're applying next year, you should be starting sometime in the summer, just so that you're not stressed out come next April. And applying early, huge. I can't stress that enough either. I think for me, that made a big difference. My first year, so the application every year opens in April. My first year, I applied in November. And then my second year, I submitted, I think, in mid-May. And then I had interviews. I got 3 interview invitations about 2 or 3 weeks after that in June. And so I already was accepted to 2 programs, one that started the August the following year, and one my program, which started in January. So both of my acceptances were, one was about 5 months before school started, and one was almost a year before school started. So that gives you an idea. A lot of these programs are rolling admission, meaning they are accepting applicants as they come in, and they're reviewing applications as they come in. They don't interview every single candidate, and a lot of schools only have a set number of interviews that they're willing to, like, interview invitations that they're willing to give out every year. So it's really important that you take that into consideration. So the earlier you apply, the better your chances are. And if you think about it, the earlier you apply, when there's less people in the application pool, there's less people for them to compare you to. As you move further and further into the application, or closer to a deadline, more people, of course, are going to be applying to try to get their last minute applications in. So for those students, it's a little bit more competitive, because there is more, there are more options for programs. And then, of course, if you've interviewed, it's a major success. Give yourself credit for it. To give you an idea, my program that I attended had 1,200 or so applicants that year. They interviewed about 200, and about 24 of us were accepted. So that's huge. So getting the interview from 1,200 to 200 is a big step. Waitlist is not a bad thing. We tend to see waitlist as a disappointing, disappointing news, but it's not. Waitlist, I mean, so many people come off waitlist all the time. If you guys have ever attended a virtual shadowing with me, my friend Mike did one in urgent care. He's one of my best friends from PA school, and Mike got off the wait list like a couple of days before orientation started. So it happens, and that he's not the only one. There's so many stories like this. And so waitlist is not a bad idea, because the school has to have a wait list so that they can ensure that they're filling their class. That's one. Two, students do put down deposits for schools that maybe they're not, very enthusiastic about attending. But of course, an acceptance is an acceptance, in PA schools, PA schools. So most people will put down a deposit for any school that they get into. And I do recommend that. But I also recommend, as soon as you find out from the school you've been waiting on, if you get in, give up your seat at the programs that you've put deposits down on, to free up that spot and give it to somebody else. Well, 9 out of 10 times that open spot is going to come, it's going to be filled from somebody off the wait list. So that's why wait list is not a bad thing. For any rejections, you just brush it off the best you can. I know it's easier said than done. And then you learn and grow and you get ready for the next one. And then, of course, acceptance, best feeling ever. And then you just relax, and prepare for life as a PA student. So what is a physician assistant? A lot of you guys know this already, I'm sure, but let's go over it. Very common interview question. So a physician assistant is an advanced practice provider. We obtain patient histories, we perform physical exams, order and interpret labs and imaging. We create treatment plans and prescribe medications. We do perform minor outpatient procedures, and we're generally first assist in the operating room. We're trained as a generalist, meaning from pediatric to geriatric. We're versatile in our practice, and with that being said, the versatility takes us a long way, because that's what allows us to just pick up and move specialties as we desire. And then we have the balance of autonomy and collaboration, as I talked about. And we're also bridging gaps between medically underserved and quality medical care in this country, which is a huge thing, because we definitely need good healthcare in this country. So what does an urgent care PA do? Broad scope of practice, any specialty. So in an urgent care, if any of you guys work as MAs or scribes in an urgent care, you know that anything and everything will walk through that door. Earaches, chest pain, shortness of breath, lacerations, dislocations, tons and tons of things, abscess. I mean, anything. It's kind of limitless. Right now, we do see a lot of COVID as well. No 2 days in an urgent care are the exact same, right? You just never know what your day is going to be. It could be a very slow day. It could be the busiest day you've had in your, string of shifts. I mean, you just never know. We address patient presentations, again, the variety, right? Rashes to infections, to all of that. COVID testing, of course, we test for work, school, and travel clearance. We test for exposure. We test for patients who are having symptoms. For the patients that are having symptoms, I do my evaluation, and then I decide if they need a COVID test or not. Most patients, I will tell you, get a COVID test, because you could have somebody that comes in with not shortness of breath, of course that, but you might have somebody that comes in with just a sore throat. But now, we're living in a time of COVID where people do only have sore throats and during COVID. And so that's no reason to exclude a COVID test, because if you think about it, you miss one, and then they go and infect everybody else because they think they don't have COVID or weren't tested for it. And then they go infect multiple people, and now you have a bigger issue. So COVID is always in the back of my mind. You start IVs, so hydration, right? People coming in for dehydration is pretty common. We drain abscesses, we repair lacerations, we use sutures and staples. So in the head, we typically close head lacerations with staples, and other minor procedures. Most lacerations we can handle in an urgent care. I've had a couple of instances where, one was an adult, one was a child. So for the child, the child just would not lay still. Just nothing was working, and the child was just fighting. So we tried everything. We tried all the numbing and everything that we could, and it just wasn't working. So talked to the mom and dad, and I collectively, we decided that the child should just go to the emergency room. I told mom and dad, they're not going to put him under, but they will probably have like a bear hugger or something like that they can put him in, to prevent him from moving his arms and legs, while they're trying to fix his laceration. And I had an adult who was having really bad pain with her laceration. The laceration itself was a pretty simple one on her finger, but she was having a lot of pain, so I wasn't getting a good physical exam on her. And she wanted to be put under for the laceration. And I told her, nobody's going to be able to put her under most likely for this, but The only other option she would have would be to go to the emergency room because I did think she needed sutures. So that's what she did. She opted to go to the emergency room. You know, it's not the best use of resources, but I tried, and that's all you can do. And then you document everything that happened. Workers' compensation, my least favorite. There's a lot of paperwork, but we do see workers' compensation injuries as well. Lots of paperwork, close follow-ups, things like that. Medication refills, bridge therapy only. Urgent care is not primary care. We are a step between primary care and the emergency room. So coming to an urgent care for medication refills is okay if you can't reach your doctor and maybe you just completely forgot about your medication, you know, having to refill it, whatever it may be, that's fine. But it's not a primary care where you can come in every month for refills, which some patients do. And then we just remind them every time they come in that, hey, yeah, I can only give you like a week at a time. So that's what I do. I only give about 5 to 7 days at a time. And I stress the fact that you need to see your primary care for this. And people will come in for refills on anything. They'll come in for refills on like controlled pain medications, which I personally don't prescribe unless there's some indication that you need it. And they'll come in for, I've had patients come in for like Viagra. Those patients too, I tell them you need to follow up with your primary care because you know that's not an urgent refill in my opinion. Patient education, of course, this is important not only in urgent care but in any specialty you go into. Very, very important to make sure your patient's educated. So my case study, I had this case a few months ago, still one of the most interesting cases I've had. And it's one that I think about often because it's just one of those things where, you know, you rely on what the patient tells you, but as a clinician, you also sometimes have to think beyond it. It's not that you don't trust the patient, but you have to go with your gut instinct as well. So 28-year-old female came to the urgent care clinic. She came pretty close to when we were closing. I think she came about like 7:15, 7:30. We close at 8. And that's the other thing about urgent care that I forgot to tell you guys. So we typically are contracted for about 14 shifts a month. Our shifts are 8 to 8 and one provider. The company that I work for, the health system that I work for is we have 6 urgent cares on the island. And so every clinic has, of course, like a full staff of MAs, full staff of front care, front desk, patient service representatives, and then they have one provider. So it can get hectic and busy at times. Typically for me, I work about 16 to like 20 shifts per month, and that's by choice. So she has abdominal pain and she's concerned about a urinary tract infection. She's had it before. Vital signs. So blood pressure, good, pulse, good, everything looks good, temperature and everything. Abdominal pain is 7 out of 10. You can get abdominal discomfort with urinary tract infections if they're really bad. And then her last menstrual cycle was October 30th. I saw her, I believe, a week later, 2 weeks later. Current medication, she's on ibuprofen only for the pain. No known allergies, no past medical history, and no surgical history. Subjective data, so history of present illness. This is basically what I'm typing out as far as what the patient told me. So it's the story they're telling me. Subjective is what the patient tells me, so it's their symptoms. It's not a sign, it's nothing that I objectively can feel or, you know, lab data that I can see. So she's telling me she had a sudden onset of sharp cramping, abdominal and pelvic pain, 7 out of 10 since 3 p.m. that day. So she came in about, you know, 3.5, 4 hours later. She had associated symptoms, nausea, vomiting, cramping, hematuria, meaning blood in the urine, pain with urinating, and then spotting for 2 weeks. The spotting for her, I asked about that. So her spotting is, she mentioned it to her OBGYN. So the OBGYN said that she was going to be monitoring it closely. She had already seen the OB like the week before for the spotting. She had a really bad UTI, urinary tract infection in January of last year, and she was hospitalized. This feels the same. No new sexual partners, no chance of pregnancy. She's not on any birth control, no history of sexually transmitted infections. And then she denied all of those symptoms. Dyspareunia is pain with intercourse. Flank pain is a pain on your back on the right and left side, right over where your kidneys are. Can be indicative of a kidney infection, kidney stones, things like that. Physical exam, this is the objective data. This is what you examine on the patient, the signs. So general, she's non-toxic appearing. She's alert and oriented. She came in with her mom. Skin exam was normal, respiratory, cardiac, everything normal. Abdominal, the sounds were all normal. She did not have CVA tenderness, so over her flanks onto 2 kidneys. She didn't have any tenderness back there, so I wasn't worried as much about a kidney infection or kidney stone. She had severe tenderness to palpation in the right lower quadrant and the pelvis, and then guarding. So she had a positive Robsing sign, which is where you palpate on the left lower quadrant, left side, and she feels pain on the right. She had a positive obturator sign and positive psoas signs, again, specialized tests. And then McBurney point tenderness. So between your the front of your pelvis and your belly button, if you go 2/3 of that distance starting at your belly button, McBurney's point is right there, and it's right over the appendix. She declined a vaginal exam, and then her mood and everything was fine. She was pleasant, though she was in pain. So the specific signs. So Rovsing sign, again, you palpate on the left, you feel pain on the right. McBurney's point. The obturator sign is pain with internal rotation of the right thigh. So you have the patient lay back, and I just turn their right foot inwards, rotate the right thigh internally, causes pain in the lower abdomen there. And the psoas sign, I have them lay like on their left side, and I pull their right leg straight back, and that causes pain in the right lower abdomen. So all of these signs in her were positive. So objective data, urinalysis that we do in the clinic. So here, the important things. So she has got blood in the urine. She's got leukocytes, the white blood cells, but not very many. It's plus or minus. Her nitrites are negative. Also, generally, we see leukocytes, nitrites, and blood in a urinary tract infection. Appearance was red and cloudy, so that makes sense because she has the blood in the urine. So for her pain, I thought her pain was a little bit out of proportion, to the fact that she just thought she had a UTI in the urinary symptoms. I felt like she was having too much pain, for it just to be that. And then, of course, her pregnancy. So she denied pregnancy to me and the medical assistant, but I did a pregnancy on her because her period was 2 weeks ago and she'd been spotting, and so I just wanted to do a pregnancy test on her. Does anybody have any guesses as to what her diagnosis may have been?
An ectopic pregnancy, maybe?
Yeah, that's a good guess. So yeah, ectopic is a good one. So these are my diagnoses. So what are the possible diagnoses? And you want to go from most likely or life-threatening to least likely or life-threatening, because again, in an urgent care, my decision making needs to involve, can this patient go home and just be monitored by her primary care, her OB/GYN, or does she need to go to the emergency room now? And that's probably the hardest part about working in an urgent care. And so my first guess was a ruptured ectopic pregnancy, exactly, because she had the spotting, she was having severe pain out of proportion, though it was over the appendix, and that's hard to differentiate. At that point, you need imaging, right? I mean, at 7:30 on a whatever day of the week it was, she's not going to get imaging anywhere other than the emergency room right away. Um, then you're also thinking ruptured ovarian cyst, but she wouldn't necessarily have a positive pregnancy with it. Ovarian torsion, twisting of the ovaries, but again, won't necessarily have a positive pregnancy. Appendicitis, of course, and then cystitis, which is a UTI. I mean, she could have had the UTI, right? I mean, she had some signs of infection, but she could have had the UTI plus something else too. It's not that you can't have multiple, but these are my top 5 differentials for her. So again, same thing. Disposition is, where does the patient go next? What am I doing with the patient? Is she stable enough to go by private car if I'm sending her to the emergency room? If she's not stable, does she need an ambulance called? What is the next step? So for her, of course, I sent her to the ER because I do think she had a ruptured ectopic pregnancy, and I think that she was. I think I felt like she was going to continue just losing blood, and of course, I mean, it needs to be treated and possible surgical intervention. So a normal pregnancy is, fertilized egg implants on the uterine wall. About 300 million sperm enter the vagina during intercourse and ejaculation. They either flow out or they'll die in an acidic environment. Some of them pass through the cervix into the uterus, so they use the cervix. through the uterus into the uterus here. The uterus does destroy many sperm, considering them as invaders. Half of the sperm will travel to the fallopian tube with the unfertilized egg, so the tube here. A few dozen of the original sperm remain by the time they reach the egg. Some of the sperm burrow into the egg. So the first sperm to make contact will fertilize. So the fertilized egg in an ectopic pregnancy, instead of implanting in the uterus, it implants elsewhere, the fallopian tube being the most common site. So they can implant anywhere: the cervix, the fallopian tube, abdomen. The embryo develops and grows in areas that aren't meant to strain and be elastic. I mean, anybody that we know, if anything that you know about pregnancy, you know that the baby's growing in utero. And so this uterus expands. It's meant for that, to hold a whole human body before birth. And tubes and other areas, ovaries, I mean, those are not meant to expand the way the uterus expands. So usually with an ectopic pregnancy, we usually can detect it during the first trimester because we start seeing symptoms and all of that. And it can be life-threatening because if it's a ruptured ectopic pregnancy, you can lead to internal bleeding, and over time, you can, there's loss of life involved there if you don't get care. So what happened to my patient? So I follow up on all my emergency room patients. I called her the next morning because I was working. And even if I'm home, I do call my patients that I sent to the ER. So in her case, they did an ultrasound first, no intrauterine pregnancy. So there was no embryo in the uterus. And but of course, we have this positive pregnancy test. So there's something somewhere. They did a CT scan and they saw hemiperitoneum. So they saw blood in the peritoneal cavity. The appendix was normal. So now you've ruled out appendix. There's a 2-point decrease in hemoglobin. So she's losing blood and hemorrhaging. So they did because they saw blood on the CT scan, but couldn't definitively see what it was. And she was losing blood. They needed to go in and they see and look. So now that's why it's exploratory, because they don't really know what they're looking for, but they're going to go in there and look and see if they can find the source of bleeding. Ruptured ectopic pregnancy. So she had a pregnancy in her right fallopian tube. So they ended up removing the right side, her right tube, as a life-saving measure. Otherwise, I mean, obviously she would have kept bleeding out. She was discharged after 12 hours of being observed, and then had a follow-up with OBGYN outpatient. Her products of conception, they'll continue to shed for some time. She came to the clinic 5 days after her procedure, and she just came to verbalize the appreciation for the care she received, which was really sweet of her. We don't always get that, nor do we expect it, but that was really nice of her. So treatment options: surgery you would do when you have a ruptured ectopic pregnancy like she did. Hemodynamic instability, which is what she was going to, she was heading towards, and then intraperitoneal bleeding. She had all three of them, and so that's why it became surgical. Non-surgical options: you detect an ectopic pregnancy, but it hasn't ruptured, and no signs of hemorrhage, things like that. You can do methotrexate. Of course, you don't see intrauterine pregnancies with these. You confirm or suspect an ectopic, and you have abdominal pain, but without the hemorrhage or the bleeding. That's the case. You guys have any questions about that or about anything else like PA related? How old was the patient? She was 28.
I'm sorry, I may have missed this, but what's your work-life balance like?
So that's very it's not, that question isn't like PA driven necessarily, like for my work-life balance. It's more specialty driven. So right now I work about 16 to 18 days per month. And when I work, I have 12-hour shifts. For me personally, because I have my like my pre-PA mentoring and all of that on the side, the days that I'm off, I'm doing revising personal statements and doing mock interviews and stuff like that. So I feel like I never have time off. But 16 to 18 shifts per month, 12-hour shifts. When I was working in sleep medicine, and they can be random, like I don't work, I try only working like 2 weekends a month. That's something that I get my scheduler to kind of work with me on, is just the two weekends per month, so I at least can get 2 to myself. But when I was working in sleep medicine, for example, it was a Monday through Friday job, and so it was like a 9 to 5 clinic day. Every weekend was off, so more of a set schedule. So the work-life balance is really dictated by the specialty. To give you a contrast, my husband is a hospitalist physician, and he's contracted also for 14 shifts, just like I am. But his shifts are 1 week you work 7 days in a row, and then you're off for 7 days in a row. Personally, I like that schedule better, just because if you want to go on a vacation or anything, you don't really have to worry about planning. You already have these built-in weeks that you know you're already off, because you know you're working the week before. And so I personally like that better, but my urgent care doesn't schedule that way. They prefer us to do 3 or 4 in a row and then take a break and then come back and do it again. So yeah, that's my work-life balance. Let's see, how frequently do you find that patients require a visit to the ER as opposed to treatment in the clinic? That's a good question. Some days are better than others. Yesterday, was it yesterday? No, day before yesterday I worked, and I think I sent day before yesterday I sent 2 patients to the emergency room. One was a chest pain, and his EKG looked okay, but he was like sweating in the clinic, and I couldn't differentiate acid reflux and GERD versus cardiac related chest pain, because he had a personal history of cardiac events in the past, and he had a family history. So, and then given how much pain he was in, he felt better after I gave him aspirin, but that was it. I mean, I had given him aspirin, so I couldn't tell. Though his EKG was normal. So I sent him, and he went with his son. I always offer ambulance, and most patients will say no, but some of them that are just not stable, I don't give them much of an option. And you have to be upfront with patients and let them know that, hey, you're risking life here. Literally, there could be a loss of life if you don't adhere to this, and it's against medical, it's against medical advice. And we do have forms in the clinic that patients have to sign, acknowledging that they are acting against medical advice. It protects us, right? So, we do take it as far as that if ER is recommended and they don't go. So that same day after the chest pain, I think later that afternoon, I had a child that came in. He's like 9 or 10 years old, was at the skate park. He was skateboarding on the ramp, and he fell, and he used his hand to brace his fall. And so when he braced his fall, the dad showed me a video, and you could see like the top part of his arm just kind of like shifting down. So you could tell just from the video alone that he's fractured something. And he ended up fracturing both his radius and his ulna here. And because he's a kid and his bones are still growing, I thought he needed to be seen right away, and then possibly have surgical repair, like pins and screws or something. So I sent him to the emergency room, and then some days I don't send anybody. So it just depends. Are there doctors at my urgent care? Are you the main person in charge? Yeah, it's just me. So when I'm working in clinic, it's just me. Every clinic has just one provider, and in our group, there are, I want to say there's like 10 or 11 physicians, and there's 2 PAs, so me and one of my colleagues. Let's see, try to look for in-person shadowing opportunities. Yeah, I do. I think I tell everybody, start with your primary care. It's somebody that knows you, you know them. Start with them, see if they'll let you shadow them. If they're not allowing it for any reason, they might know somebody else that's allowing it. And primary care is always a good network, because they just know you, right? They're going to know you more than any other doctor, unless you know a doctor yourself, other doctors or PAs. But start there and then branch out. They'll network for you, you can network through them. There's so many options there, so definitely reach out to them. Let's see, sneeze. Okay. Would you recommend volunteering outside of patient care hours to strengthen an application? Yeah, you totally can. Any work that you should do, any work that you do, remember that you're doing it because you want to do it. Not everything you do as a pre-PA has to be driven towards PA school. If there's something you're passionate about, like I have students that I work with right now who I have a student that I work with who does Humane Society, like she volunteers at the Humane Society, and it's really important right now, especially during the pandemic. A lot of these humane societies, initially, they were getting really packed because people couldn't afford to pay for their pets anymore. But then at the same time, a lot more people were staying home who could afford it. And so a lot of humane societies ended up emptying out. But she was working and volunteering with the Humane Society for the majority of the pandemic. And I think that's really important. And that's something that I would put in your CASPA because I think it shows well-roundedness. But that being said, not every little thing you've ever done has to be in the CASPA. That's the other side. So there needs to be a good balance. Is this going to make a difference, or is this just becoming redundant, or whatever it may be. Have you ever considered working in an ED, or why urgent care versus ED in your case? I like urgent care because I like the variety of cases that I see, not that the emergency room doesn't see it, but I do like being right in between like primary care and the emergency room. I'm not somebody that wants to do like high level of trauma, or only see like chest pains. Not that the ED only sees chest pains, but a lot of people with chest pains, right, are going to go through the ED. So I don't want to just be limited to higher acuity type of stuff. I do like seeing some of the lower acuity not so sick patients. So I like that balance in the urgent care. Otherwise, I mean, most of what we do and what the ER does is the same. It's just the level of acuity is a little bit lower in an urgent care, and I like that. Would you be comfortable sharing weaknesses that prevented you from being accepted? Yeah, so in undergrad, I feel like I didn't do well my first year of undergrad, and then any of you that have not done well in a class or a few classes know that it takes a lot more work and a lot more effort to bring up one grade than it does to like bring your GPA down with that one grade. So for me, it was a lot of having to bring my GPA back up. I also applied very late. Like I said, I applied in November. The application opens in April. No, by November, all interviews are already given out. So yeah, and so for me, I did my master's for that. I knew that I wasn't going to really use my master's for anything. And I ended up being able to use it a little bit the year I applied to PA school after my master's, which was nice. But I knew that my master's was a stepping stone for me to get into PA school. And I think that's ultimately what made the difference, was my master's plus applying early and then revamping like my personal statement and my experiences and stuff like that. I had to reword a lot of things and really work on a lot of those things. Do you think that programs value PA shadowing over MDs? I've been exclusive, but work with MDs. Every program's different. So there are programs out there that'll say, shadow an MD, shadow a PA, shadow an NP, but the program has to be the one to tell you what is or is not okay. And not every program, there's no standard, and I wish there was, but there's not. So different programs do have different requirements or things that they see as strong. And so you always want to reach out to the program yourself and find out what they value. Are you aware of PAs in Hawaii that are doing in-person shadowing? No, I was until COVID started in my sleep clinic, and then I went to fully like seeing patients at home. But I want to start having patients or students in my urgent care. I really want to have students in urgent care setting, and I'm waiting and hoping that it can happen soon as more and more people are getting vaccinated and we're seeing less COVID. I do still see COVID, not every week, but I had one case this week that I know of. The second one that I tested the last day that I worked, that one was probably positive too. I didn't follow up on her, but she was probably positive too. So that, it's also that, because we have enough PPE, but every shadow student that we have, like, they would have to change PPE for every patient they see. And so there's also that. So multifactorial, but the biggest thing being with COVID right now, and not because we don't even allow, so if you have a patient that's coming in. Like we have patients sometimes that come in with 4 or 5 of their friends or family members, and we don't even allow them back in the back. It's just the patient, unless there's like a language barrier or they're a minor or some compelling reason. It's just the patient that can come to the back. After undergrad, what jobs, volunteering, or internships did you have? I just worked as a pharmacy tech. And yeah, so HIPAA is a big part of it. I completely like skipped over HIPAA, but HIPAA is definitely the biggest part of it. HIPAA is a big reason, like the biggest reason why we couldn't do shadowing via telemedicine, because not every, like, you know, when the pandemic first started, we were just using Zoom for virtual shadowing because Zoom, it was okay to use like one that wasn't HIPAA compliant because we wanted people out of the clinics and at home as quick as possible. So that was an exception that everyone was willing to make, you know, to say this isn't HIPAA compliant. So anytime I would talk to a patient, I would just say my blurb about how it wasn't a HIPAA compliant platform. And because of that, though, I wasn't able to have students shadow me either. Will you be posting on your IG if you're able to start in-person shadowing? Yes, I will. So whenever my company allows in-person shadowing, I will definitely post it on my Instagram. So for any of you guys that are local to Hawaii, which I rarely ever find, and I'm always excited to find them. Anytime you guys, if you guys are able to see that, you can certainly reach out to me and we'll get something set up. Let me see what mentoring thing. Okay. So for my mentoring, pretty much like, so not everybody needs mentoring. That's the first thing. Not everybody needs somebody to look at every part of their application or anything. If you need like a second pair of eyes on it, you just need somebody to revise and give you feedback, whatever it may be. You're always welcome to reach out to me. And I'm not the only one out there doing this. There's so many other people doing this. So you have to go with somebody you're comfortable with. For me, it's my experience from my program and my involvement with the interviews that kind of brought me to this point of wanting to do this for somebody else. And so I do mock interviews, CASPA, I review your CASPA experiences. I go through your COVID essay, your personal statement. We go through it twice. So I do the first one, you revise it, and then I do the second revision after you've refined it. We do consultations. I do look over supplemental essays for 2 programs that you're applying to. So it's like an overall package kind of thing. But if you only need certain parts of it, we can also just do like certain parts of it. It's really up to you. And again, like, you know, not everybody needs this, but if you feel like you're somebody who needs it, reach out to me and I can send you the information about it. And my email, I'll put my email in here. It's also in my Instagram, which I'm putting in here. So if you don't get the email for some reason on Instagram, you'll see it. It's in my bio. Tips on what to include in the COVID essay. Yeah, so the COVID essay is obviously it's not going to be around forever, right? It is here this cycle. It was here last cycle. The COVID essay is going to be pretty much like, what have you done during the pandemic? You know, schools want to know. Schools know that you're not the only student that wasn't able to get in-person shadowing, right? They know that you're not the only one that maybe lost their job due to COVID. And those are both things that you should include. But is there anything else? Like I have students I'm working with now who have worked in the students went to, they did the like they were an MA or a scribe or whatever they may have been, and then because of COVID and their clinic not seeing as many patients in person, their hours were cut back. So what they did is they were looking for other outlets or other like job opportunities, just anything they could do to supplement the income and the experience. And they came across helping at COVID vaccination sites, you know, whether it's administering vaccines under the guidance or supervision of a nurse or whoever it may be, or it's like setting everything up for the administration, whatever it may be. They did COVID testing. So a lot of them did like drive up testing sites. Those are really cool things that you can talk about because you're showing that you're versatile. You're showing that, you know, hey, look, like this is what happened to my job, but I didn't stop learning. I didn't stop like trying to help and trying to push forward and trying to gain more experience. And of course, it's very, very valued even more so because you are working to help with this pandemic. So I think that's like a big thing. So those are the kinds of things you want to talk about in your COVID essay. Sometimes students make the COVID essay their personal statement, and it's not. You know, it no longer sounds like a COVID essay. It sounds like their personal statement, but there's a separate spot for your personal statement. The COVID essay is not the place to put why you want to become a PA and what you're doing to become a PA and all that stuff. That's not the COVID essay. The COVID essay is how has it impacted you financially, academically, you know, whatever it may be. And it does have a prompt. So when you guys open CASPA, you'll see there is a prompt with the COVID essay. Any other questions? Common interview questions would be why PA? What is a PA? Tell me about yourself. Why X, Y, and Z program? I would say those are like biggest strength and weaknesses. Those are the few that come to mind as far as what you should be doing, or what questions you should definitely prepare for. And then of course there's variations. I mean, there are programs that may not ask you any of those questions, but and then there's lots of variations and lots of other question styles as well. So things to consider. All right, you guys. Thank you so much for having me. I enjoyed talking to you guys. And if you guys have any questions at all, feel free to reach out on Instagram or via email. I do my best to get back to you guys as soon as I can.
Thank you so much, Archana. That was a great presentation. If anyone has any more questions, feel free to send me it and I can reach out to Archana and hopefully we can get back to you. All right. Thank you so much. Have a great day.